Hey, good morning, everyone, and welcome to UroNurse. Good to see everybody. As you can tell from my background, I'm remote, but a different area remote. I'm over in Denver, Colorado today. So glad to be with everybody for another episode of UroNurse. If you're watching us from any of those formats, glad to have you on board. And hey, YouTubers, don't forget to hit that subscribe button. YouTube is our number one on-demand place to watch the show. And I do have an announcement. This week, we went over the 100,000 views on the UroNurse channel. So it's great. And actually, I looked at the channel this morning, and it went way beyond 100,000. We're already at 104. If you're new to the show, be sure to check out our website at uronurse.com, the best place to go to learn more about the show. Also, that's the best place to find all of our past episodes, and there are 78 of those. And hey, if you're not getting our e-news, be sure to check that out, our email. Through MailChimp, go ahead and register on our website for that every Monday e-news about what's going on with UroNurse. Now, if you want to watch us in your car, no problem. We do have an audio podcast available through our UroNurse Plus area. If you haven't checked out UroNurse Plus, check it out. There's a lot of little shorts there, but it is the best place to check out our audio podcast. And we've got a really great show for us today. We've got Dr. Landon Trost, who's going to be joining us to talk about Peyronie's disease and that contraption for traction that I think it's really going to be interesting to learn more about. And with that, let's go ahead and bring in our experts right now. Good morning and welcome everybody to the show.
Good morning.
Hey, everyone.
Thank you. Good morning.
I'm going to start off with my introduction. My name is Vic Sinise. I'm the host and producer of the show. Been involved in urology for the past 40 years, and this is my way of giving back. And I'm glad to be able to share every Saturday with everybody on different coasts throughout the country. Lori, go ahead and bring in your introduction.
Good morning, everyone. My name is Lori Atkinson. I'm a certified urology registered nurse. Been in urology for 25 years, and I currently work for a urology practice in Winfield and Geneva, Illinois. And I'm happy to be here, and I can't wait to hear more about Peyronie.
And John, go ahead and give us your introduction.
Good morning, everyone. My name is John Lynn. I'm a private practice urologist in Gilbert, Arizona. And like Vic, what I'm doing is paying it forward, sharing what little I know regarding the clinical and business aspect of urology. To that end, I created a Facebook group called the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit, and it is all for free. And when they tell me it's free, I'll take 3. Can I share one little tidbit regarding coding?
What? Sure, go ahead.
Yeah. So new CPT code 99459 is for pelvic examination. There's been some debate regarding whether or not you need a chaperone. I hear from a very reliable source that you do not need a chaperone to use 99459. It is an add-on code and pays practice expense only. For those of you who are employed, being credited with work RVUs, you will not get any work RVUs using that 99459 code. It does benefit the facility. So if you're in private practice, definitely use it because it benefits the bottom line. Back to you.
Very good. All right. John's always good for some information on coding. And Landon, our latest our add-on for today, our guest host, is going to be talking. Go ahead and give us your introduction and we'll get the show going.
Sure. No, it's my pleasure to be with you. So very much appreciate the invitation, and nice to be among such a wonderful group. My name is Landon Trost. I'm a urologist. As far as background, I did my undergraduate training at Brigham Young University, went to med school at Tulane, and did my residency at Mayo Clinic. And then I stayed on staff there, did 3 fellowships in andrology, which is a subsection of urology that focuses on male sexual medicine and infertility. Was the chief of andrology at Mayo Clinic, and absolutely loved it there. It was the highlight of my life, but I was so busy that my wife said, you have to change jobs. And so after trying to control life, and Vic and I were talking about this a little before the show too, but I finally said, all right, I'll change jobs. And so I went and opened up my own practice. It's a practice, private practice, like Dr. Lynn, called the Male Fertility and Peyronie's Clinic. So we literally, just do those 2 things. During my time at Mayo, though, because I was over andrology, we would deal a lot with Peyronie's disease and with traction therapies and things like that. And because of that, we saw a big need to develop it. And Mayo had a real neat system where if you saw a need of something that needed to be developed, you could email a group and then they would develop it. And so I worked with a team of engineers there to develop a traction device. And that's basically what we're going to be talking about today. So,
all right, very good. Let's bring up your slides.
Okay. All right. Yell at me if you can't see it. So I titled this one Penile Traction Therapy from Gimmick to Legitimate Therapy, mostly because when you look at the history of a lot of sexual medicine products, and traction in particular, it really fell into this kind of back of the magazine, gimmicky type thing for the longest time. And I'll kind of show our experience too and what led to the development of the RestoreX or the second generation traction devices. But a lot of sexual medicine things, it becomes very difficult sometimes to differentiate something that is good and legitimate versus that's kind of a scammy type thing. So we'll talk about that and we'll go into data. This may be a little too data intense on it, but I think it's good to know. And I think people like to see the core data, behind anything. So as far as disclosure, so I did invent RestoreX. I've been very strict about conflicts my whole life. So I've never taken a penny from any company under any circumstances if I had any control over it whatsoever. When I invented this at Mayo, though, it was kind of a different setup where when you invent something, you automatically get a portion of royalties, things like that. At the time, Mayo told me, they said, hey, you can either invest in the company or you can do studies on it, but you can't do both. And so I said, well, I'd rather do studies on it because we don't want to put out some scammy type thing. After I left Mayo, the company itself, I was able to buy shares in Pathright Medical. So I own stock in Pathright Medical. It is held under a blind trust, though. And so technically, from a conflict standpoint, it doesn't, it isn't considered because it isn't a blind trust. So, but I just wanted to be aware that you are going to get this from a bias standpoint, because clearly if I invented something, then I think it's going to fix the problem. But even then, we made sure we did some studies to prove that it worked before we did anything else. So, all right, just a couple of caveats about traction in general. It is a relatively new therapeutic class. A lot of things in Peyronie's disease have been out for like 50 years plus, but traction really is about 10 to 20 years or so. And when you look at published outcomes, 3 authors in total account for roughly 80% or a little more than 80% of published original articles out there on traction. So if you really get into the insider baseball side of it, you'll start to realize that, you start to see the clusters of data and how they kind of come together based on the authors that are there. There's very few devices that are registered with FDA, and actually even fewer that are even legally allowed to be sold up in the United States. So you can purchase these. They'll generally come from another country, and it's generally done illegally. And if you look back on the news, so Fast Size was one of the early ones. This is back in 2010, and FDA at one point went in and basically stopped all sales and production of it because they weren't following any of the rules. They weren't doing any of the things that you're supposed to, and so it just shows this area is ripe with abuse and kind of misrepresentations and things like that. This is just some online things. I got rid of the names in it, but you can see, there's a lot of mislabeling, false advertising fraud, that's out there for, traction in general. Like this particular one says more penis circumference, enlargement of the glands. I've never seen traction devices that, have any data to prove any of that. And then, try risk-free 6-month unlimited growth guarantee. It's the only clinically proven device offering a massive 2,800 grams of tension. Like none of that is accurate. That's almost 50% more than any of the leading devices. Again, completely not accurate. But there's a lot of misinformation in medicine. And so it becomes a question of how do you sort through snake oil versus legitimate therapies. This is another one where they're quoting, clinical study on this. None of this study is published anywhere, and certainly not in clinicaltrials.gov or any legitimate, sources for it. So with that background in mind, traction is used pretty much throughout the whole body in different areas. You've got braces for teeth. That's a form of traction. You've got scoliosis there in kind of the front center. And then, of course, you've got traction they use for orthopedic type indications. It's clear that the body responds well to traction in different areas. The mechanism behind it isn't well understood, though. And when you look specifically at the penis, this was a well-done study by Eric Chung and his colleagues. And in this particular study, this was a rat model of things. They noticed that there was an increase in MMP8, which is responsible for degrading collagen. Collagen is one of those things that causes curve in the case of Peyronie's disease. And they saw an increase in smooth muscle alpha actin. So this type of thing shows that you actually get reductions in alpha actin after traction, and you get this increased MMP8. So there is a mechanism by which when you stretch something, the body kind of remodels it. And you see that with other things too, like with orthopedics. If you use a bone a certain way, the bone will remodel over time to adapt to that force. And sometimes you'll see that with spinal issues where you'll get these, osteophytes and different things because of tension that's being pulled on different structures. So there is a mechanism there. Now, historically, all devices kind of fell within this first generation category. And I've just listed a couple here. So you've got Andropenis, X4 Labs, Pennymaster, Palisade Fort. And you can see, and I think you can see my mouse as well, they all use this same type of traction mechanism. So they all have this same type of a spring type mechanism. Now, the problem with these systems that I found is they only will contract and extend about a centimeter from max contracted to max extended. And the problem with that is when you try to stretch the penis, body tissues just move more than that. So if you put a little bit of traction on it, the fat part of the body and the suprapubic area is going to push away and you lose all the traction. So in reality, you end up with almost no traction at all. These systems also are only able to generate about a pound of force with the traction on it. And then they use different type of clamping systems. Like this is kind of a noose-like system that goes behind the head. This is kind of a double clamping. This is a suction cup. And they all have issues like suction cup, of course. You put suction on something and you get kind of petechiae or, more loose term hickey type thing where you get kind of suction effects. But then it can form blisters. It can pop off and create like cork type sounds. So there's a lot of limitations, to these systems. You can add additional rods that you screw these on, but to do it, you have to take the whole system off, add it all on and then put it all back together. And you lose that ability to dynamically adjust or to add traction to it. And again, most aren't registered with the FDA and have real limited force with it. So this was a animation that Mayo Clinic put together. And you can see some of the existing systems, how they work. When you add the force to it, it puts a lot of force just on the one area of the clamp. And you only get a little bit of advancement. So you're just not generating much force at all. Now, because of that, when you look at the requirements of first generation devices, you have to wear them for like up to 8 to 9 hours a day. And even the manufacturer instructions generally recommend around 5 hours a day, minimum 2 to 3 hours a day. And that's difficult. Can you imagine doing anything other than sleeping, 8 hours a day? And so clinically, it's hard as a doctor to recommend a therapy if the patient has to do it for 6 months, 8 hours a day. It's just not feasible with normal life. Now, even in those that did do that, you can see that a lot of these were not significant. So curve improvements were not significant. Now, this one I'm going to talk about real briefly. This is a real standout study, a real outlier of a study. And they're, in this case, men with Peyronie's disease, they're showing a 31-degree curve improvement. Now, just to put that in context, that would be basically equivalent to surgery to improving curve. And we'll go over that one here in just a second. So that particular study was done out of Spain. They had 80 men who completed the study. It was never registered as a clinical trial. Now that generally is not considered acceptable. I work with the Journal of Sexual Medicine, and most journals will just not allow any randomized clinical trial if it's not registered with clinicaltrials.gov. The benefit of registering a clinical study is you say at the outset, here's what we're going to do, so you can't change it after the fact. So it prevents you from manipulating data and things like that. The study was also not intent to treat, and that's pretty much unheard of for randomized controlled trial because intent to treat says, if the patient doesn't do it, that still counts, because if I give someone chemotherapy and they get so sick from it that they can't finish it, that should still count because that is a side effect of the treatment. They had numerous exclusions in the study. It would have excluded 90% of men in our randomized controlled trials. And there are a lot of red flags. There are a lot of key details missing. We don't know how they measured length. We don't know the actual utilization in the study. We don't know the results from the control group as far as the actual core results. We don't know standard deviations. Again, this is very unusual for a randomized controlled trial. All the results were compared against baseline rather than between groups, which again is not acceptable for randomized trial. And the outcomes were very suspect given the study size. So they had a p-value of 0.03 for length changes. With a study of this size, we've done multiple randomized controlled trials, and I've never seen something like that. So there's a lot of fishy data, going on there. The compliance was reported at 96% at 3 months for 21 hours of therapy weekly. Now, historically, data has showed that the compliance is about 9 to 56% for 3 hours daily, let alone 6 to 8 hours daily. So again, this is a lot of big red flags on this one. And just to give you an idea, our randomized control trial had a 53% compliance with only 1.5 hours daily. So in any case, just wanted to highlight this one because it's the only one that stands out in the first generation device studies. Now, when you had other authors, so these are secondary people who don't have incentive toward that particular study, you can see that they're showing no difference. So first generation devices, this included all of the devices that we've shown so far. There was no change in curve difference. Length was maybe 0.2 to 0.4, some of those non-significant. And our own experience at Mayo, we looked at guys who did use these devices. This guy used the device 750 hours of these first generation devices. And basically this line is flat. If the line were, sloped, that would say that the more you used it, the more likely you were to get a curve improvement. But in this case, we saw no improvements whatsoever, no matter how much they used these other devices. So there wasn't even a trend towards benefit, saying, well, maybe you just need another 800 people to prove it, for example. So at the time, I was on the International Consultation for Sexual Medicine Guideline Panel for Traction Therapy, and saw this data that I just showed you from our internal data. So I ended up buying a couple of the devices. Andropenis was one of them, but I bought a couple of the devices, and I just tried them out. And I just realized that these were just kind of scammy things. Like they just, weren't legitimate type therapies in my experience. So that's when I contacted Mayo Ventures. They're the group that designed things. This was like our original prototype out of Legos, believe it or not, of saying this is what you have to develop and invent. Another company, Pathright Medical, bought the licensing rights from Mayo. And then before I allowed them to sell anything, I made sure part of the agreement was that we were going to do some randomized controlled trials to prove that it worked, so that we weren't, another scammy therapy out there. There were 3 main changes that we made to the device. The first was the clamp design itself. So we went through and redesigned the clamp so it's more of like it distributes the force more broadly over the whole head of the penis. So it's not just one small area of the penis taking all the force. We added counter traction in there so that you could focus the force more aggressively on the areas that needed treatment. And then we added dynamic adjustment, which allows you to lengthen it while it's still in place so that you can maintain the traction. So those are kind of 3 key changes that we made. And here you can see the animation that shows kind of difference. So, head of the penis goes in there, the device is advanced, and then you extend it. And you can see it achieves about 3 to 7 pounds of force. But as you stretch it, you'll get to a point where it's just not working as well, like it's not delivering as much force. You can then dynamically adjust it or advance it and then re-engage it so that you're staying in that kind of therapeutic range, which is that 3 to 7 pound range minimum for it. Well, it's great on paper and it's great to, try to put out a salesy type thing, but does it actually work and does it actually, do any good? And that's where the randomized trials come in. So we designed 3 randomized controlled trials out of the gate. One was in Peyronie's disease, and that was looking at treating both curve and length. Another was diabetes, and then a third was post-prostatectomy. Now, I specifically chose those 3 because they're generally considered to be 3 of the hardest to treat groups overall for penile length and things like that. So I wanted to see, is this a legitimate good therapy? All of them were registered with clinicaltrials.gov. All of them had very rigorous protocols. They were intent to treat. They were all comers. We had photographs, second party measuring, things like that. So we designed them as rigorously as we could. This is just one of the study designs. You had Peyronie's men randomized to one of 4 groups. This was trying to figure out the dosage. So once, twice, or 3 times daily dosage. We then did our assessments after 3 months, and then we had an open label phase. And I'll show you some of the data here, just high level. So at 3 months, the most important thing for us at the outset was, is this safe? And so we asked people specifically at the end, did you experience redness? Did you experience any changes in sensation? So this wasn't self-reported. This was us asking them specifically, do you have this? And that's important because when you ask someone something, you tend to get much higher rates compared to if you just make them self-report something. And you can see that we did see, about half the people, when they first start using the device the first week, they get kind of minor pain with the clamping, with stretching, and that resolves within usually seconds of taking everything off. And also, after you take the clamp off, the penis is red for a second. So we did see all this, but everything resolved. We didn't see any permanent long-term issues, and none of these were considered even moderate or significant type complications. So basically, key finding was it was safe. Outcomes wise, we looked at length and we looked at curve, and using different measurements, because there's different ones used in the literature, you can see that all of them showed statistical significance. And really you're looking about 1.5 centimeters, so maybe 2/3 of an inch or so was kind of the typical length with it. From a curve standpoint, we saw that you're roughly about 12 degrees curve improvement. Now, when you compare that against control, you're roughly about a 10-degree greater improvement, or about a 20%. So again, compare that against the other, that outlier study that I mentioned, where essentially they're saying, this is, in some of their groups, it was more than a 50%, type improvement. It's just, it just shows you kind of more realistic of what outcomes kind of typically are. Now, this type of a plot, you can see how each individual patient lined up in the study. And you can see that roughly a quarter of the men had a 20-degree or greater improvement. And then you can see, like, again, compared to that other study, they only had one guy who would hit that 50-degree, type improvement. So just, to put things into context. Now, length improvement, roughly a third would gain more than an inch, 95% gained some improvement. And again, the average was 1.6 centimeters. Now, surprisingly in the study, and this one I did not believe at first. In fact, I was hesitant to even publish it because I didn't believe it. And in our first study, we even said, we don't believe this result. But it showed improvements in erections. Now, this was not a dramatic improvement. So like Viagra will usually improve someone by like 5 to 9 points, for example. And this is improving people by 4 points. So keep that in context. It's not a dramatic improvement, but it appeared to improve erectile function as well as overall sexual satisfaction and intercourse satisfaction. So again, in our first study, I thought this was a spurious finding. You check enough variables, you'll find something that's statistically significant, even if it's really not. So, but we did see, intercourse satisfaction, overall satisfaction appeared to show a signal that, all right, maybe we were seeing improvements, and that made sense because your curve improved there. But again, erections didn't make sense to me. So we broke it down by groups and said, all right, how about men with no erectile dysfunction at the outset? And we saw that those guys generally did not have a change in erections, but those who did have erectile dysfunction to start did see improvements. So those with mild had less than those with moderate, and those with severe. So this was more of a finding that this may actually be a legitimate finding. But it's tricky with Peyronie's disease because you don't know if someone penetrates, is that why their erections are better? Because now they can penetrate, whereas they couldn't before. So again, we kind of still attributed it to maybe a spurious type finding. Well, asking people, do you have a preferred treatment? They appear to prefer traction in our study, so RestoreX specifically in our study, compared to other therapies for Peyronie's. Because Peyronie's is kind of an aggressive therapy type condition. You've got, collagenase, which is an injectable, causes a lot of bruising. Surgery, of course, has lots of side effects from it. Oral therapies don't have tons of side effects, but they generally don't work very well. And so at the end of the study, we saw there was a preference towards RestoreX. But this is always biased. If someone goes into a clinical study doing something with RestoreX, of course, they're going to come back and say they're glad they did what they did and so on. So you always take these types of things with a grain of salt. But at least it didn't show that they said, hey, I hate this therapy, it was the worst thing ever, type thing. Now, in the study, we looked at counterbending to try to decide, did counterbending actually matter, or was this a gimmick? And we found that those in the study who did not get to at least 90 degrees of the counterbending in cases of mid to distal curves, they did not get as good an improvement. And so it validated the concept that counterbending is an important aspect of correcting curvature in a study, or in Peyronie's disease. Now, real quickly, if we look at like the 6-month data, you can see that those who continued to do it, so those who had done therapy previously but did it for 3 extra months, they continued to gain additional length, but it was a small amount. So Peyronie is probably more reliable here. So you're looking roughly 0.5 centimeter. Now think about that. So that's 6 millimeters after 3 more months of use. So you do, and when we've looked at even longer term, you do continue to gain length, but it's a very slow rate. So usually for people, I just tell them you need to just keep counting the clicks, and every 3 months count and keep track in a diary if you've achieved further clicks. But importantly, we did not see further curve improvements. And again, this is highlighting, I don't have time to go into it, but that one study that I mentioned where there's a lot of those red flags, in their study, they showed continued ongoing improvements every time. And we just did not see that at all, even with a more aggressive type therapy. So again, major red flags in that other study that I highlighted. So again, this validated the findings from the randomization phase. And the key take homes here were you did continue to gain length, but at a slow rate, but no further curve improvement after those initial 3 months. Well, everything before this was intent to treat. So if someone dropped out, we still had to include their data. But what if you looked at people just as treated? So only those who actually did therapy and did it as recommended. Well, in that case, we do see better improvements. So you see roughly an inch or 2 centimeters, and you see a 14-degree improvement. So slightly better improvement, but again, nowhere near that one red flag study. And then erectile function did start to pop out. So you see that those who had erectile dysfunction at baseline, they improved by 6 points. So now that gets to be something actually clinically relevant, something that's actually important. And then intercourse satisfaction, overall satisfaction, sexual desire, all of those also improved. And it kind of makes sense if your function improves, and a lot of times all the aspects that relate to function start to improve too. Clinically meaningful. So there is a threshold within erectile function where you define something as being clinically meaningful, meaning that it's enough of an improvement that you consider it meaningful. And you can see that if you looked at those who used it as prescribed, you're looking roughly 60% of those with severe erectile dysfunction, 100%. Now notice it's only 4 men who had moderate erectile dysfunction, mild, 60%. So you're looking roughly 2/3 would say, hey, that was a meaningful improvement in erectile function of those who did it. Overall satisfaction. So you have 3% who are dissatisfied, and then the remainder are either neutral or satisfied with therapy. How does it compare to other devices? So 10 of the men had used other devices, and 100% preferred it to other devices. And knowing what you know now, if you could start completely over, what would you do? And after 6 months, this is where everything kind of finalized out. But again, remember, this is always biased. You're always going to get people who are going to bias toward what they did. So key findings: it was the first device to demonstrate improvements with 30 minutes of daily use. So instead of this 5 to 9 hours daily, you just use it 30 minutes a day. So now it's actually truly clinically relevant. It was the most rigorous study ever performed to date with traction devices, and it confirmed length and curve improvements, and had this question of erectile function improvements. And importantly, there were no persistent adverse effects after stopping therapy. Well, real quickly, I'm going to, for the next maybe 5-10 minutes or so, going to go into just some other data, including, the erectile function side. When you look at how can stretching something improve erectile function? When you look in mice, whether you take an artery or whether you take erectile tissue, anything like that, and you stretch it, you do see release of nitric oxide from it. And, a lot of times they'll have these, tests where if you're going to draw blood, you'll flick the vein for a little while to get it to dilate up. And it's using that mechanism where mechanical or tensile stress on certain structures will cause release of nitric oxide. Well, the penis is lined with those types of structures. And so it actually kind of makes sense that by stretching it, you may actually release this nitric oxide, which makes it improve erectile function. Well, this was actually proven out in a rat model of traction, where they showed upregulation of nitric oxide synthase. And you can see that happens around 30 minutes. So as early as 30 minutes, you see this peaking of endothelial nitric oxide synthase in this case for it. So in any case, there is a mechanism. It was shown in the studies to actually be a legitimate type mechanism for it. So, and I just found it real interesting that a lot of this peaks at that 30-minute time point, because that's where we also found our peak benefits. All right, real quickly, any comparison studies between first and second generation devices? Yes, there was one that we did looking at XIAFLEX alone, which is a medicine you inject for Peyronie's disease, versus XIAFLEX in first generation traction versus XIAFLEX in second generation traction. So there's 113 men in each of these groups. For the first generation devices, we did recommend they use it at least 3 hours a day, whereas second generation, we said 30 to 60 minutes a day. These were generally started within a couple days after XIAFLEX. And then the patients had separate info on device usage. So basically every time they came back, we'd have them report how much they actually used the device. And this study was neat because none of them were measured by, or the measurements were obtained by 10 to 12 different providers. So you're seeing a big smattering. It almost acted like a multi-center type study in that way. And you can see those who did other devices, they ended up only using it about 1.9 hours a day. So that's about what people can do. Whereas with RestoreX, they did 0.9 hours a day, a little bit more feasible there. It's very difficult to be compliant with more than 3 hours a day of therapies. And you can see those that used other devices, there was no difference compared to if they didn't use a device versus a first generation device. Whereas with RestoreX, we did see greater curve improvements. We saw greater length improvements, but we just didn't see any differences when someone used a first generation device. Length was the same thing. You see length improvements with RestoreX, but you don't see it with first generation devices. So this is the only head-to-head comparison one. And when you look at relative curve improvements, again, these were small numbers at the time, so always take this with a grain of salt. But what the key thing is, you see second generation traction does make a bigger difference compared to those first generation devices. So the summary there were no observed benefits with the addition of first generation devices. All right, one final kind of topic to go through is post-prostatectomy. So one of our randomized trials looked at men post-prostatectomy, because commonly on the sexual medicine side, the big complaints we hear about are length loss and erectile dysfunction. Now, granted, you don't do a prostatectomy. You're doing it for cancer causes and things like that. So there's certainly really important reasons to have it done. But there are side effects to having the prostate cancer treated. And there's debate on length loss and then erectile function. So this was our study design for the post-prostatectomy study. Basically, they had a prostatectomy, and then starting around 1 month, they would either do traction in a low dose protocol, like once a day, 30 minutes a day, 5 days a week, or a high dose, so twice a day, 7 days a week. And then we analyzed the results at 6 months and then did an open label phase as well. Well, in this one, we saw increases in length. And again, very similar to our other studies here, 1.6 centimeters. So we're seeing that consistent improvements in length. Interestingly, though, we did see a reduced need for intracavernosal injection therapies. So fewer men were needing these to get erections post-prostatectomy. So again, this was when we started to maybe believe for the first time that there may actually be an impact on erectile function. So here it was 20% versus 50%. Again, very small numbers. So n equals 21, n equals 16 here, but it's supporting that prior finding that we saw. So again, we looked at erectile function here, and those who had baseline erectile dysfunction had an improvement of 5 points, which was similar to our other study, compared to a loss of 6 points in the control arm because they underwent surgery. So they, of course, lost erectile function there. So it appeared to help preserve erectile function better. And when you looked at all comers, they basically ended up being flat. So even though they had surgery, we saw a mean improvement of 0 points versus minus 6 points in the control arm here. And then again, we saw this intercourse satisfaction, overall satisfaction domains maintained even though they had a prostatectomy, which is very, very unusual post-prostatectomy, as those who've treated men post-prostatectomy know. Well, when you break it down a different way, so this is looking at the data a different way, and you look at control versus RestoreX at baseline and after treatment, you can see that at baseline, erectile function was pretty similar between the two groups. But post-treatment, you have less of a drop if you're using RestoreX compared to if you didn't use RestoreX. Your erectile function, at basically 6 months is significantly less. Now, this will restore to some degree in men as time goes on. But again, we saw a big difference between these. And again, this was statistically significant for it. And then the overall satisfaction, intercourse satisfaction, you can see that big difference between this dark blue and dark red groups there. This ended up being a real major finding. So this is the biggest contribution to improving erectile function or preserving erectile function post-prostatectomy, which has ever been shown, with the exception of nerve preservation. So nerve preservation was this big, remarkable change in urology because now you start preserving erections post-prostatectomy better than you did before. But since nerve sparing, it's notable that no therapies had ever been shown to improve spontaneous erectile function. I'll show you real quick a slide on, Viagra, Levitra, Cialis. Those are commonly used to try to preserve erectile function, but they've been shown not to work. And vacuum data was only shown while you're actually using the vacuum. There was no washout period. But despite that, a lot of people do use pills and vacuums, things like that, post-prostatectomy, even though there's data showing either no improvement or no data. So this is one of those studies that I show. So this was men who had vardenafil post-prostatectomy. And you can see that after they quit taking it, so these were men who took it post-op for a period of time and then quit taking it to see how they did. And there was no difference compared to if they didn't take it. So no benefit in taking PDE5 inhibitors from a preservation of erectile function standpoint. This was the largest randomized control trial. And again, it showed no difference after washout, no benefit on a subsequent PRN response. In other words, you can take it, no harm, and you get benefits while you're taking it, but it doesn't actually heal anything or prevent damage to anything. This was another study, this one looking at tadalafil, same thing. You can see on the right here, after washout, it was as if they never took the therapy at all. So there was no benefit in taking it compared to not. So this was the first therapy ever to demonstrate improved erectile function post-prostatectomy that was done in a randomized controlled trial with washout, things like that. Now, there are limitations. We can't really design a sham for this, because how do you design a sham mechanical device? It's also as a single center, which you always worry about. But the strengths, it had moderate study power. It was consistent with other randomized trials. It showed continued benefits after washout, and it did use standardized assessments. So there were a lot of strengths there. Now, we're currently doing an international multi-center study to try to replicate the findings. It's going to have 250 patients. If you ever have interest in enrolling in a study like that, you're certainly welcome to. So we're going to see if we can confirm those findings. So just in summary, so final slide here, first generation devices have questionable clinical efficacy. And even if they did have efficacy, the problem is they have to be used for 3 to 9 hours daily, which really precludes their use in clinical practice. Second generation devices are good at lengthening. They're so-so at improving curve alone, though, in Peyronie's disease. Ideally, it would be used in combination with either Xiaflex or surgery, something like that. And again, they're great at length, but curve, you're looking maybe a 10-degree improvement is a realistic expectation there. Now, post-prostatectomy, it does appear to preserve erectile function post-prostatectomy, and we're looking to do a real big randomized trial, multinational, to confirm this. Now, even if it does confirm that, hey, these devices do improve erectile function, I don't think anyone's ever actually going to use these to improve erectile function. So it's a neat, cool finding. It's a somewhat of a spurious finding. But who's actually going to do that? I mean, it's far easier to take a pill than it is to use a device 30 minutes a day type thing. So I don't think it'll ever be used necessarily for that indication. Now, post-prostatectomy, I think there's going to be a role there, a real important role. But I think as a primary treatment, not so much. With that, I will turn the time back over to you. And I think I need to hit a button to stop sharing this somewhere.
You're good. We got you back on the screen.
Okay.
All right. Well, that was great. Very interesting. I'm going to kick off the questions. And of course, audience that's watching, feel free to put anything in the comment box with questions for Dr. Trost. So now, how long, generally, if you're using this for Peyronie's treatment, how long is somebody going to be staying on it? I mean, is there, 3 months, 6 month data, but is this something you have to do permanently or?
No, we actually looked at that as far as let's say you stop, does everything regress is one of the questions. Because sometimes there are some therapies that happen that way. And so we had the open label phase where people could use it, not use it. And we looked at the people who quit using it and looked at their measurements. And it looks like it regresses maybe like 1/3 of a centimeter. And that's probably just kind of ligament stretch type things. And then it stays put after that. And so usually when someone says, hey, should I keep doing it? If they're doing it for curve improvement, I tell them after 3 months, it looks like you're kind of optimized and you're not going to gain further benefits there. And that's assuming you're not doing it with Xiaflex or doing it with surgery or something. I think that's a different group. But length, if someone says, yeah, I still want more length, then I tell them just to keep a diary and keep track of the clicks. Because if they do it for another 3 months and they didn't notice another click, I just tell them, don't keep doing it. You're going to spend your whole life doing this thing. But if they do keep track of a diary. If you see that the clicks keep going, then you can keep using it as long as you want in that regard. Now that's just, me clinically. I don't speak on behalf of the company. I don't have I'm not employed by the company. I don't, ever receive a salary from the company, anything like that. So they would have different language where what the instructions for use allow them to say, one thing or another. But from a clinical standpoint, that's what I tell people.
Good. I'll open it up to my experts if they have any questions.
I have lots of comments. It sounds like You mentioned nitric oxide increases with stretching. Then wouldn't it make sense that stretching with masturbation would help?
Yeah, you'd think so from a erectile function standpoint. The only thing is sometimes when guys get, severe erectile dysfunction, they can still masturbate, they can still achieve orgasm, but they never get actually a good strong erection. And so I think the people that are getting good strong erections, it's likely part of the reason that they maintain good erectile health, because whether they masturbate or not, if they have nighttime erections, typically people will get 6 to 10 nighttime erections. That should be stretching things out and kind of maintaining function. But when you get erectile dysfunction, now suddenly things aren't stretching anymore. You're not getting those nighttime erections. And when you, like post-prostatectomy, you permanently, or you lose erections rapidly post-prostatectomy. And so you're not getting that stretching. And what happens post-prostatectomy is and I didn't have time to show any of these slides, but you get scarring of the penis when it's not being used over time. There was a great study by Iacono and colleagues out of Italy where they biopsied the penis every couple months, and they showed progressive fibrosis that started setting in. So my theory on this is if you're stretching it post-prostatectomy early on, it's almost like the power went out to the factory and you put a new generator in there temporarily so that all the employees don't leave. And then once the nerves start regenerating, 6 months in, the nerves start regenerating from a prostate. Now the factory's still working, you can restore power. And I think that's why we're seeing that preservation longer term compared to not. Whereas normally you lose erectile function, all that scarring starts setting in, your body finally heals those nerves, but it's too late. The scarring set in and you just can't restore that function quite as well.
The old adage of use it or lose it applies here.
Then it's proven true now.
Cool. So I'm going to call you the Tom Liu of Utah.
Hey, I'd be super flattered. Tom is such a wonderful guy. So
yeah, Tom, I actually have referred someone to Tom Liu out in the West Coast with Peyronie's disease, penile curvature.
Yeah, Tom's a wonderful guy. I guess I've known him probably close to 15 years now, and just such a neat, wonderful guy. Still practicing, so still out there practicing.
Amazing.
Yeah.
And it's interesting that after prostatectomy, with the stretching, that you are able to regain 1.6 centimeters in length and decrease intracorporeal injection treatment. That's awesome.
Well, isn't that crazy? Yeah. Again, and we ran these studies at the same time. So we did all of the randomized studies at the same time. And when I saw the data coming in, I just thought, oh, this is spurious. Like how would it make any sense, But when we started getting that secondary data that they're actually using fewer, and it wasn't significant, but they were using less Viagra, they were using fewer injections. And so that's when we started saying, hey, there probably is something actually here. And that's when we thought, all right, let's go ahead and do this bigger study and see if it's a legitimate finding or not. Because it's such a problem in the sexual medicine side of it. It's so discouraging because someone gets their cancer treated and they're happy on that side, but then they deal with all the long-term things. And it's funny how they forget the benefit of treating the cancer. Years later, the only thing they care about is their erections. And so this was a real neat finding when we saw it.
Had this exact conversation with the patient yesterday. Let's keep the eyes on the ball here. Yeah. The number one thing is to cure cancer, and everything else is secondary. If we're able to hit the trifecta, cure cancer, maintain erectile function, maintain continence, that would be ideal. But keep that in mind. Now, people who want treatment can obviously go to male fertility and Peyronie's clinic in Utah. How else can they get RestoreX?
Yeah, so online, if you just go to restorex.com, it doesn't require prescription or anything along those lines. And so people can just order it online. And that's probably the easiest way in the United States. They just got approval to be able to launch it in Europe. And so I think they're just in the process of doing all that side of it. I believe Canada also can order it online at restorex.com. Otherwise, anything other than that, you may have to email the company. So I'm not sure.
Wonderful. So it sounds like it's 30 minutes a day. You use it 30 minutes a day. And then once you get results after 3 months, it doesn't really benefit you to continue using it.
Length, you can get further and further if you want, but curve, no. So if you're doing it for curve. Now, post-prostatectomy, we would say start at 1 month post-prostatectomy and then continue out until at least 6 months. We did do an open label. I didn't have time to go over it, but those who continued from 6 to 9, we saw further length, but we didn't, if I remember right, we saw further length, but we didn't see further like erectile function preservation. So it looks like you have a short window to do your preservation. And so ideally you'd start at 1 month and then continue till 6. After that, yeah, you can stop.
It sounds like we should consider using this or recommending this for all post-prostatectomy patients.
Well, I tend to be real skeptical of anything and everything, and so, I mean, you've got one randomized controlled trial that would say definitely you want to do it. It'd be nice to have a confirmatory one to say, yes, indeed, this is confirmed. The data is strong enough that I think from a clinician side, like if I were undergoing prostatectomy, I would, certainly do it. But do you change guidelines? Do you do things like that? I think you probably want a little more confirmatory data before you make a real hard, like people should be doing this type thing.
Mm-hmm.
I always look at that data that you presented from Italy with the fibrosis showing up in the penis. So
Yeah.
I was always a big advocate for trying to do something sooner than later. Why wait till it gets fibrotic and then try to reverse that? We did a lot of vacuum device treatment post-prostatectomy to try to maintain their erections or improve things. But the big complaint that I noticed throughout my career was patients coming in complaining of the shrinkage of their penis. And at first I kind of thought they were just, they're just being guys, right? It's never long enough. But, you hear it enough and you realize it's a legitimate complaint. So that's interesting.
No, and it's funny. We looked at that. I pulled all of the data to see, like, is there legitimacy to that? Do people actually lose length? And I found it's actually a debatable topic. Like in our study, we found that those who were just observed, they didn't lose length. And when we did the measurements, it was, I can't remember if it was plus 0.2 or minus 0.2, but basically they didn't end up losing length. And but interestingly, in their questionnaires, they said, yes, I lost a lot of length. And so subjectively, they reported it, even though objectively, when we measured it, we didn't see any specific length loss in the group that didn't do any sort of treatment. And I suspect it's probably the size of the penis is how they're interpreting it. And I think because it doesn't get engorged as much, I think it starts to scar down and it starts to fibrose. And so it may not be like a true stretched length that they're losing, but the size of the penis to them is a lot smaller. And like you mentioned, penile rehab is a hot topic, 10 years ago. All of us were trying to find like the best penile rehab protocol. Is it pills? Is it injections? Is it vacuums? And John Mulhall was a leading figure in that area. And his data basically showed it doesn't work. And, the data, they tried to do a randomized control trial, had to close it early because of, accrual and enrollment type things. And the 3 randomized other studies that were done looking at PD5 inhibitors, none of it worked. So all of these efforts and energy was put into it. And it just showed that the rehab ultimately made no difference. And unfortunately, at the time, pills were super expensive back then, too. So these poor guys were paying like $30 a day to try to do these therapies that just weren't working. So
I know we're talking about erectile function and penile length. Keep in mind that the female orgasm most of the time does not require the penis in the vagina. And I'll leave you that.
Yeah, in fact, length sometimes makes it worse. When you get too long, it hits the cervix and it becomes real painful. And so if anything, if you had to argue for anything, it'd probably be girth more than anything else. So, yeah.
Why do I feel like I'm being singled out here with the only female on the panel?
No. We're being considerate. We're concentrating so much on the
No comment.
If you're part of the statistic, then no, the penis does not need to be in the vagina to reach an orgasm.
Well, I will let Dr. Lynn go all over that landmine.
Yeah.
No, seriously, though, there is an orgasmic inequality. Most of the time when a man engages in sexual activity, he reaches orgasm, whereas a woman, that's not the same. So there's a big gap in knowledge in what gets a woman off versus what gets a man off. It's been so male-centric for so long. I think it is an important topic. Maybe we can discuss that later.
I was going to say it'd be a good topic for a whole. In fact, it'd be a good panel discussion too. You could pull in a couple different. But yeah, no question. When you look at the number of studies published, the amount of money going into pharma of different things, I mean, it's heavily male centric.
Mm-hmm.
And part of that's because there's actually solutions on the male side. On the female side, it's trickier. There aren't any. There hasn't been a Viagra breakthrough type drug. But even before that, when you looked at men presenting versus female presenting for sexual dysfunctions, I mean, it far, far outpaces it. So there definitely is a bias that way, no question.
I also have a podcast that I put out for patients. It's called the Euro Patient Podcast. And one of the questions that I usually try to address in that one, so I'm going to ask you, is pain. So a lot of patients want to know, how bad is this going to hurt? Scale of 1 to 10, 1 being like nothing. So where would you put the Restore
I
X?
found if you don't do it correctly, there's a couple like pain points that people will have when they first start using it. Like for example, when you put the clamp on and then you start stretching, the skin will pull tight. And if you pull skin in through the clamp, then it's a non-issue because you don't want the skin tight. The skin acts like a seat belt. You're trying to stretch the deeper tissues. If you pull skin in, that eliminates the far majority. The other one is sometimes the new kits that are coming out will include a makeup pad. It's basically just this little cushion that you put on the bottom clamp. And then if you do that and wrap the penis like recommended, then you have very, very minimal discomfort at all. If you don't, then it takes about a week or two until you kind of get used to it. And I would say it's like a 1 or 2 out of 10. So it's not like pain, but you can feel something stretching. And so it tends to, make it where you don't want to stretch fully. And so usually what they'll do is they'll have you ramp up. So you start like 5 minutes, 15 minutes, and then you kind of slowly ramp up. Because just like when you first go out and work in the garden, in the spring, you get like a callet or you get like a blister on your hand because you haven't used your hands all winter. Same thing happens with traction. The first time you use it, it's real hypersensitive. After you use it for a week or two, you become real adjusted to it. And after people get through that learning curve, they're able to do the full counter bending and everything that you need to. So
now it's available over the counter, so patients can just go and order this themselves. Do you think that it's the instructions are satisfactory? A patient should be able to figure this out, or is this something best come into the office and have somebody showing them how to use it?
I do think there's a learning curve to it. Anytime something's more functional, there's a little more learning curve that goes into it compared to something that's real straightforward. The instructions, they just redid them. And so the website's updated, I believe now with all the new instructions. So they did simplify them to make it a lot easier. There's also like a quick start video that you can click on and it'll walk you through like all the steps. And I know they're currently making new videos so that online you'll basically just click where your curve is. So you'll click like which you represent and it will show like a customized video just to your situation of how to set it up, how to use it, things like that. So they are going to simplify it even further. But I do find there's a couple real common errors. And on the RestoreX website, there's a couple videos they had me make a couple of years ago that addresses those common errors and how to avoid them. One of them, like I mentioned, is that pulling in the skin. And so it just, some of those easy things. Because what I found in our studies is if someone comes back and they didn't get length improvements, 100% of the time they weren't doing it correctly. And when we corrected them, they got length improvements. And so we, to date, in any of our randomized studies, we haven't seen someone not get an improvement if they were using it correctly. So a lot of it is just making sure that they're doing it correctly. Now, curve, again, 10 degrees, how do you even notice a difference of 10 degrees? That's a little bit trickier, but length is real obvious and measurable.
Yeah, great. That's all the questions I have. Anybody else with any questions? It looks like our audience was satisfied with all of our discussion.
Well, it's a sensitive topic. Not a lot of people like to say, hey, I'm Landon Trost from Colorado. I've got a question, so.
Right.
Well, it certainly looks like the majority of the people who are listening are female. So.
Well, but, honestly, like at Mayo, for example, our nurses did a big portion of the education post-prostatectomy. They probably had more time than we ever would on the clinician side to be able to go through a lot of those issues, especially when you're doing that. We called it a UCO voiding trial, but catheter removal and voiding trials. And so I found like we have this men's health nurse group who is just wonderful at Mayo. I just think the world of them. And they were a huge resource and a huge asset to be able to educate and train. Because honestly, on the physician side, sometimes you'll have 10 minutes max, maybe 5 minutes to be able to go in and do some of these instructions. You don't have time to go into orgasmic disorder and urinary incontinence with and erectile dysfunction and maintenance. I mean, your job was get the cancer out, do as best job you can, minimize complications, and then you just run out of time.
And we do have quite a few physician's assistants that take time with patients post-prostatectomy and pre-op and post-op to discuss all of this as well. So
that's wonderful.
It's a lot for patients to take in. When you start talking cancer, they kind of shut their brains off. But all those pre-op instructions. Then when you see them back, as John had alluded to, they once their cancer's kind of cured, that's when everything comes out that's bothering them. That's when you hear about I have incontinence or I have erectile dysfunction or penile shrinkage. When they're worried about cancer, then those symptoms tend to be less noticeable to the patient.
What's funny? A little side note on that. When I started my practice here, 4.5 years ago, we had like an information sheet that went out to like the Peyronie's guys, and we included all the things we thought were real important. And then as time went on, that information sheet got bigger and bigger and bigger and bigger because we'd have someone say, well, no one told me about, well, no one told me about, no one told me about. And so we'd include all those things. Once it got to a certain size, I found they didn't remember anything. And it was as if we didn't give them a single sheet. And so our current sheet of things is actually far more simplified. And we actually only have like, these are the 3 things I want you to know and to take away. And what I found over time, really the best way to do things, although it's hard to do, is time-dependent information. So like at this point, you need to know these 2 things, and then 2 weeks later at this point, you need to know these 2 things. Mm-hmm. And that's where it gets to be real tricky because we often don't have those repeated touch points when it would really be nice to have them. So,
yeah,
on the other hand, for instance, simple procedure like a TURP, some patients want to know what to anticipate. And if you don't tell them beforehand, if you try to do it in a contextually dependent fashion, if you don't tell them beforehand, then they complain saying that, well, I would have done this X, Y, or Z if I had known this was what I was going to go through. Or worse yet, everybody heals differently. So if you don't cover it, then they get mad. You really can't win doing one way or the other.
No, I agree. It's a losable battle for sure. So
exactly. You're never going to please everyone. That's for sure.
Yeah.
Well, thanks. This discussion has been great, but we are coming to the end of the show, and I always like to adhere to that. I do want to make a plug for next week's show. Join us next week. We're going to be talking about the new things that are available for doing urinary tract and urine cultures with the new molecular diagnostics. They're going to be joining us to talk about that. And panel, it's been a great discussion. I think that Peyronie's is one of the areas we had not touched in the past, so it's great to have somebody to talk about that. And look forward to doing some more of this in the future. So thanks again for everybody, and we'll see everyone next week.
Thank you.
Thank you.
Bye.
Bye.